Hey guys, welcome to the fourth lecture of the fall 2020 semester. Today we'll be talking about linking non-financial metrics to financial performance. This is Dr. Lee, and let's have some fun. There are three learning objectives for today's lecture. First one is differentiating the terminology between non-financial metrics and financial metrics. Second is listing and describing two-step process to link non-financial and financial metrics. And the last one is reviewing a case and recommend evidence-based services to improve a physician group's clinical performance by acting as a consultant to this case scenario. After today's lecture, we will be starting 2-week-long journey of learning about Accounting 101 and billing process in relation to pharmacy. Those lectures will be delivered by Dean Lingle and Dr. Wang. Before we jump into there, we wanted to really make a good connection about the familiar terminologies like the clinical outcomes that we know of, and linking with the financial metrics, so that when those financial metrics Accounting 101 lectures come in front of you, you have an idea of why those terminologies are relevant to your own practice in the future. Let's talk about some specific terminology. What does it mean by non-financial metric, and what does it mean by financial metrics in relation to healthcare? So if you recall back from pharmacoeconomics course and the learning lessons, we learned that healthcare is complicated, and in healthcare, money in does not equal to money out. When you think about the money that you earn from your labor, you think about where you're going to spend, so that income and expense are pretty balanced from the monetary terminology. However, in healthcare, medical decisions come with many different aspects, such as there are aspects of medical effectiveness of the therapy, ethicalness of the therapy, there's societal concern about whether makes sense to allocate such resource to a indigenous group versus more economically well-versed group, and so on. So there are many different factors, and that concerns about cost, access, and quality of care. Because of this complexity and not being simple as money in and money out, researchers in healthcare have really tried to come up with various type of outcomes that we can categorize. These are three outcomes that we've categorized, and it's called economic, clinical, and humanistic outcome model, and it illustrates the value of pharmaceutical product as combination of this clinical-based outcome with more contemporary measures of economic efficiency and quality. So I don't know if you guys will remember this complicated diagram about quality, but when you look at this diagram, there's a money coin that's on top right corner of the picture, and all the others are different inputs that you can kind of see. So in healthcare, money in is only a small portion in grand scheme of many different players and factors that contribute to the outcome. So it's important to distinguish the difference between non-financial metrics and financial metrics. And as you can kind of imagine, financial metrics, it really means just the economic outcome, whether it is profitable to adopt the therapy, whether the new therapy is affordable. Affordability of the therapy we briefly talked about in pharmacoeconomics course by performing and learning about budget impact analysis. So those are the things that we kind of categorize as the financial metrics. However, what about the non-financial metrics? These are the clinical outcomes, like the A1C measure, blood pressure measure, whether you received immunization or not on time, whether the person got the annual physical. Those are a lot of clinical outcome, a small portion of the clinical outcome that there are available for us. And also the humanistic outcome became very important as we focus more onto quality of life, patient and provider satisfaction. Are they mentally stable? Are they mentally healthy? What are the burnout rate among the people who's receiving the care and providing the care? So it's very easy for us within this complicated definition of non-financial metrics. What became very easy for us is there is a accreditation body that came up with this specific measure called HEDIS measure to provide specific markers for whether the institution has quantifiably met the minimum threshold that they needed to meet to provide the quality service. Let's spend some time and review the concept of HEDIS measure that is representative of the non-financial metrics that we'll be talking about. We'll use this concept to talk about the case scenario. So it's kind of like a good time to review this HEDIS measure concept that you may have been exposed to early on in the first year in the pharmacy curriculum. So the HEDIS measure is short for Health Effectiveness Data and Information Set. Almost 100% of the United States health plans use this tool to measure the performance on the care and services. So think of the HEDIS measure as a set of a standard that the health plans wants a clinic for you to meet in order to care for the patients. HEDIS measure include 90 measures across 6 domains of the care. The 6 domains include whether the therapy that you're providing is effective, effectiveness of the care, or whether people can access the healthcare appropriately. So talking about access and availability of care. How did patients experience the care that you provided? Was it good or bad? Those humanistic outcomes that we talked about. So it captures the experience of the care. And the remaining 3 are utilization and risk adjustment utilization, more into kind of like a back end of the financials. Health plan description information, and lastly is the measure collected using EMR information. So just like how pharmacy school has CPE as a accreditation body to put a minimal standard to allow what type of pharmacy school education needed to provide in order to nurture the pharmacy students. The same goes to the quality measures in healthcare too. NCQA is an accreditation body that collects this HEDIS data or lay out the HEDIS standard and also collects the HEDIS data from the health plan and report to CMS for star rating for Medicare plans. Getting a good grade through the HEDIS measure assessment is really important because it will determine whether the health plan service that they're providing are good in relation to the star rating services. This gets very directly relevant to the state or federal funding that the health plan gets, because if you have more Medicare, if you're a health plan that serves the Medicare population, you get a lot of money from the federal government to support the service, the Medicare service that you're providing. And this funding ranges millions and billions of dollars. As a quick example, a health plan with about 1 million Medicare members and has a star rating originally from 3.5, and they increased to star rating of 4 because they met some other parts of the HEDIS measure performance. For this small jump of 0.5 and the star rating measure, this health plan received $8 additional million from the federal funding. So you can kind of relatively get a really good sense how this non-financial metrics, HEDIS, such as meeting the HEDIS measure, can directly be relevant to the financial gain for the institution. The table on the right side shows the 14 different measures that are included in the HEDIS measure. Some things that a pharmacist kind of focus on are things like comprehensive diabetes care, the number of diabetes patients that you care for as a clinical ambulatory care pharmacist at the clinic, are they meeting their goal? Controlling high blood pressure, or the number of people with blood pressure control meeting the goal of gaining the blood pressure control. So if you're working for a healthcare organization in retail pharmacy or outpatient or inpatient clinical pharmacy settings, there are a set of standards that the organization has to meet to provide quality care. And we just talked about the quality care means more money into the organization through various means, including the fundings from the government because you met the minimum standard or increased the star rating, and many other means. I work at academic sector in pharmacy profession, and I follow the set rules and regulations that ACPE lay out to provide a structured education so that you guys are being exposed to various topics in healthcare and pharmacy. And ultimately, you become well-versed pharmacists upon graduation and contribute back to the society. So things that I have in control on my hand is time and semester with you guys, number of students that I will interact with, set standard that are laid by ACPE guideline, and I need to make a conscious decision of how I want to spend time to deliver the content with the teaching resource that I have on my hand, the time at my disposal, with the number of students in this course. Very similar scenario runs with this making a decision as a clinical pharmacist or pharmacist in clinic or any different settings. So when you're working in a clinical setting in pharmacy profession, you and the clinic will follow the rules and regulations of various accreditation bodies like Joint Commission. We just talked about NCQA, PQA, to meet this standard, industry standard, right? So things that you have in control as a pharmacist at clinic are amount and type of patients that you be seeing, you need to see, set standard and limited time that you have. You cannot see 2-3 patients at once. You are only one person providing service to a patient care, for one. Every resource are scarce, the bottom line is, and you'll need to make a conscious decision of how to allocate your time and effort to get the maximum output. So you'll be needing to make this managerial decision of allocating the resource most effectively. So what will be asked of you are making some conscious decision about choosing a specific project with the greatest expected financial payback to your clinic or to your organization. Selecting performance measures for evaluating the clinic's performance in relation to opportunity to, again, maximize the reimbursement for the services provided. In order to assess the success of a project or an intervention that you devise, you need to know that the project that you chose made a sensible financial payback. You will be reviewing the project reports that are financial metric heavy in nature. So as part of an analogy, let me share the work that I do and how I feel that this topic is very relevant to the job that I'm performing. So if I need to know that the midterm exams that I have administered in my course is fair and appropriate, I look at the reliability and validity scale that the report generates through the statistics heavy report to ensure that the quality of the education that I have provided is translated well into your short-term growth in learning. Long-term growth in learning, we assess it through the outcomes using the PICOA or NAPLEX result to gauge the success of our educational intervention in nurturing the future pharmacists. So just like that, just like how I am equipped to decipher statistics heavy report to gauge your success, because that is an intervention that I'm giving as part of the academic career to understand your growth in more metric heavy terminology. As you will, as a pharmacist working in clinic or retail setting, you might be asked to decipher your effort allocation, whether that has been well translated into the organization's physical year profit, and so on. So in doing so, you'll be asked to interpret some financial metric heavy report, and understanding this balance sheet, income statement, cash flow statement, understanding the intricacies of the billing process in both ambulatory care and community pharmacy setting will help you to feel prepared and communicate the findings to your teams that you're managing. So the topics that are taught in pharmacy management course is really not to make you an accountant, but they're taught to enable you to review and understand the financial document as a manager to make a sound decision to allocate resource wisely within your organization. Here are some fundamental questions that you'd like to ask to successfully link the non-financial metrics or the measures with the financial metrics. So some questions that you like to ask are, what should we be measuring? What are the key drivers of the financial success? How do you define the success of the intervention? How do you rank or weigh different non-financial measures? So if you are looking at different type of performance measures within the HEDIS measure, there is effort allocation for diabetes specific, blood pressure, hypertension specific. What do you think that which disease topic is more important for you to address? Because you have, again, limited amount of resource that you can allocate, and there are many different types of diseases that you can choose from to make an intervention. How do you make trade-off among different type of measures? So for example, what are the lost cost? What are the lost opportunity? Are you effectively allocating the resource to maximize the profit by assessing what's been lost too? And ultimately, all this type of fundamental question is leading you to choose the right performance target. And this will all make sense a little bit more tangibly to you as we work toward to go through some examples and going through the case scenarios. So keep these fundamental questions in mind as we proceed on today's lecture. There are a lot of ways to address these fundamental questions, and I would like to talk about these 5 different ways that we can kind of quickly think of. Now, I could just do it based on an intuition. This is a scenario of I've been in the industry for a very long time. I know this industry, I know our customers, so whatever I say, it will make sense. If I predict that it must be true if X goes up, Y is going to happen in the long run. This is my intuition, therefore I want to do it based on my general experience. Now, as we are talking about this, you guys can kind of think about the fundamental flaws of this, right? It's coming from just one person, and the person's intuition, you don't want to rely on that because you're making a really important financial decision that will determine whether your institution is going to succeed and live in the long run. And so you want something more evidence-based to make the decision. Now, you can go a little bit step further and say that you know what, I want to gather a whole bunch of really smart people to sit around in the room and decide these financial measures are going to lead non-financial measures are going to lead this financial results. Most of us have been in the meetings where consensus really means who's the loudest, right? You have a dominant voice on a table and we generally follow the person's opinion. Again, this is not evidence-based information, and this may put the institution into a risk of following something that doesn't really have any substance. So you could go and do some measurement framework or benchmark study as a next more evidence-based step. Let's say you have a scoreboard and you collected 4 different measurement categories of setting up a success of your intervention. Let's kind of put ourselves into a perspective of looking at a patient with diabetes. That's your goal. The clinic's physical goal is to manage diabetes patients better so that ultimately you get better reimbursement from the insurance carriers of those patients with diabetes. So how do you judge the success of diabetes control? You can kind of see that A1C control being less than something, or you could also see make it relevant to diabetes complications. Do your patients get eye exam, food exam annually to meet the standard? So you have many different categories to call the success of your intervention. And you, based on the categories that I define as a success of a project, I can take that and use a benchmarking study. That means understanding what is the best practice and the current practice and try to adopt that into my practice. But you can imagine how one clinic's best practice may not be the best practice for yours, right? So your clinic might be located in a very low socioeconomic region of the country. It has very different demographic, different insurance coverage, different risk factors. Smoking might be a big problem in your region that drives the CVD risk factor for your patients. However, if you're trying to see the best practice, and the best practice is published based on by the Kaiser Permanente, which is a health system that serves the rich and well-versed part of the region in the northern or southern California. Adopting the best practice that this healthcare system, Kaiser Permanente, has adopted may not be very useful to you and your patients. So how can I more specifically figure out what is best for my clinic, right? That's the fundamental question. You could do an informal data analysis. So as you can see, we're moving on from a very raw intuition into kind of try to utilize the data to predict the future. Before we talk about the predictive analytics, some people who's kind of like freshly getting into this evidence-based research data screening can do some informal data analysis. What this is you can plot some kind of Excel spreadsheet, take a look at which parts are correlated from one another, what kind of measures are the best predictors for your final outcome, And you advance your skills and you think that informal data analysis is not rigorous enough, then we want to move on to this concept of predictive analytics. So we are doing a little bit more rigorous analytics with the tools that we probably will have all capability of doing so. So most of our current software programs have this capability. So one will say that as we have a lot of data, we are living in a very data-rich era in healthcare. We have a lot of data, but we have very little information. So what we're trying to do in turn the data that almost every company has into information or has that. So again, we talked about how we're living in a very data-rich environment. A lot of data is available, but how to interpret this information is what the special skills are needed. So this is where the predictive analytics method comes in healthcare. It's basically just a simple statistical techniques to analyze what's available, what's happening historically using the existing data to make the predictions about the future or otherwise unknown event. We casually did it through the informal data analysis, through the concepts that we learned in pharmacoeconomics, such as doing a budget impact analysis to predict the future 3 to 5 years of affordability of the new drug therapy that came out in the market. So as you can see, you have all the information that are available. You're creating some sort of a report and analysis, monitor the outcome that is very relevant to you, and figure out what kind of a future that you're predicting. This type of analytics method are being used not only just in healthcare, but in many different consumer behavior sectors like business, banking, finance, retail, relevant to retail pharmacy, telecommunications, and credit scores are kind of like a large sectors that uses this analytics. Healthcare definitely is playing a really big role as we move into the EMR system rather than the paper-based system to capture patients' hospital admission and their medical record. We have rich data stored on electronic form. So the problem becomes, how do we analyze this, and how do we make a good sense of using it to predict the consumers, in our case is the patient's behavior, so that we can maximize the benefit in our end. So you might ask, if all it needs is someone data savvy to come and analyze the data stored in the EMR system, why do we need a pharmacist skill, right? That's a very valid question. Don't we just need a computer guy? Answer to this question is absolutely no, right? So you need somebody that understands the patient care in order to make a linkage between a clinical data point and what's being performed to link it right back to the performance measure. So for example, if you have a lot of data points that says something about A1C control among people with diabetes, and you want to make it relevant to the amount of insulin being prescribed in their prescription, without having a good understanding of the difference between the basal insulin versus short-acting insulin type, you cannot tell the good story about effective A1C management in relation to insulin prescription, right? Your clinical knowledge kind of plays a role in terms of interpreting and being able to logically making a linkage between one outcome to the other. And you can probably tell more information based on the type of insulin that they use regarding the patient behavior of taking medications appropriately. So we need somebody with a good clinical understanding of a disease or therapy topic, and we need the good clinicians to be able to link it up with the data that is available. So the simple question of, can we just have the computer guy do it? No, because you need a special clinical skills that is relevant to the healthcare question that you're looking at. So evidence-based or scientific approach becomes very relevant to our discussion, and the process is very similar to conducting a research, right? You want to develop a good hypothesis, test that hypothesis, and incorporate the result to decision-making and performance evaluation, and hopefully all doing that in our example of A1C control. Our goal of A1C control is not just for the humanistic clinical outcome of let's have a better A1C management among people with diabetes. That measure becomes very important because it directly is related to the reimbursement figures, like millions and billions of dollars that the clinic may be getting by well managing people with diabetes. So in order to do all this, there are two specific steps that I like to talk about in today's lecture. And these two key things are: one, identifying the key right drivers, and two, setting the right target. So again, today's lecture is not relevant to the financial metrics, which you'll be given ample time to talk about that with Dr. Lingle and Dr. Huang. Today, we're talking more specifically with the non-financial metrics and how do we identify those key identifiers, key parameters, and these two steps of identifying the right drivers and setting up the right target will set you up to link the non-financial metric with the financial metrics in the future. So let's talk about step 1 of identifying the right drivers. What does it mean by identifying the right drivers? What you're trying to do here is developing a causal model to link up a certain outcomes into their different paths. So let me break that down. You're basically trying to say is A is going to lead to B, B is then going to lead to C. Therefore, if you want to achieve the financial outcome of improved C, you want to target A through the path of A leading to B, B leading to C. So by linking these outcomes together, you're trying to identify the specific, reliable, and valid driver. What it means by the reliable and valid measure, it means that what you're trying to measure is consistently measuring what you're trying to measure without fluctuating too much. So for example, if you're wondering about hypertension control of a specific therapy or drug, you want to measure the blood pressure, not the hemoglobin A1C, right? So for the valid measure to assess the hypertension control, it's through measuring the blood pressure measure, not A1C. And this is, you want this measure to be reliable in terms of consistently coming with a similar number within the reasonable standard deviation of a parameter. You're basically identifying the reliable and valid measure. And you want this measure to be specific. We just simply talked about the clinical outcome, but when we talk about the humanistic outcome of patient satisfaction, so let's say if you're asking, are you satisfied right after a person visited a retail pharmacy, you can get some assessment out of how satisfied are you as a customer, but a customer may have different categories of items that makes them being satisfied by using the retail pharmacy. So in order to get more specific information, you want to make the satisfaction question into more specifically, are you satisfied about the waiting time at the pharmacy? Are you satisfied with the list of the retail over-the-counter top items that the pharmacy had at the time of your visit? Are you satisfied with the customer service that you experienced at the counter? So by specifying the different types of satisfaction, you can get more information out of by identifying the right drivers. So this happens with, again, this HEDIS measure. I talked about the 90 measures from 6 different domains. So the domains are kind of like differentiating different satisfaction into different domains, right? So in this HEDIS measure, you're assessing the outcomes from the 6 specific domains that we set as an important measure. So let's take a look at this example of a major chain retail pharmacy. So we got a major chain retail pharmacy, and the company's got about 6,000 plus stores in the United States. Some of you may think of Walgreens or CVS. This is a hypothetical situation, but you can kind of imagine it's a very similar scenario to the CVS and Walgreens business model. So they offer in-store purchases. They also offer delivery services as well for selected stores. And they discovered that their overall profitability was not growing enough to meet their standard, meet their internal and external expectation. So senior management is really not happy, and they have met through a series of meetings, and they have built this consensus model that we'll be reviewing in the next slide. The consensus model, again, is linking up several parameters into a causal model to show it as a chain reaction of A leading to B, B leading to C, C leading to D, and ultimately wanting to achieve the final outcome of understanding the profitability of the company. So this consensus model that we'll be reviewing was developed using a management intuition. So one could say that this is developed through the consensus model that we briefly talked about, that was a little bit advanced from the one person's intuition, but again, still not very scientific in terms of building the model based on who's the loudest in the room. But you gotta start from somewhere, and without really doing a upfront data analysis, this causal business model was established to examine the current performance. So as you can see in this consensus business model, there is a final outcome of sustained growth. This is a profitability, whether you have performed better than your competitors whatsoever. But as you can see, the items that are leading to the growth is, yes, customers coming into your store and purchasing, filling their prescription medications multiple times to come back. So consumer buying behavior directly influences the sustained growth. But when you look at the customer satisfaction drives the customer to come to the store, and when you look at another causal place, what drives the customer to be satisfied, that's the employee's added value. More satisfied employee provides a good value to satisfy your customer. The customer comes back and drives the growth, and ultimately all the way toward the front of this causal model, there's a selection and staffing item that keeps the employee satisfied. So now if you look at this diagram again, under each one of these round circles, which is the basic causal model, there are more specific things that we think that captures that action. So, and these are where the performance measures are in terms of selecting the right parameters. So for example, if somebody wants to know that customer buying behavior as part of the leading factor from the customer satisfaction, how do you get the customer satisfaction? You just don't simply ask, are you satisfied, but rather want to look at what's the satisfaction from the timeliness of the response from the customer service. Was it specifically related to your shopping experience in terms of going into the retail shop and going through the stocks that they had, or was it the quality of the items that you have encountered on this at the store? So as you can kind of see this, the items that are listed on the rectangular box is more specific to address that a specific causal model item that you have identified. So when you look all the way back to the front of selecting and staffing that causes the employee to be happy and satisfied, you can kind of see that different performance measure items that are listed in the rectangle are quantity, the number of staffs that they have. I'm assuming a little bit more in a store, like more technician help that you have in your store causes your pharmacist to feel happy because now you have a division of labor that you can allocate amongst a different more staff that you have under control. The type of education is the staff having higher education causes the employee to be more satisfied. Was it a prior work experience that your colleagues bring to the table drives the employees to be satisfied, and so on. So you have many different measures that you can assess to identify it as a staffing problem or staffing issue that is relevant to the employee satisfaction and moving forward. So here is what actually happened based on the causal model that we just looked at. First of all, if you believe in this model, the key thing that I care about is really the employees first, right? Happy employee yields the happy customer, yielding the more profitability to the organization. So what they did is they take the employee turnover as one of their primary metrics for the decision making and a performance evaluation. And again, this is based on a simple intuition based on a consensus model that they built. We just know that this might be true. So now with this model being built, you're testing it out whether that's true based on the data that's available. So when you think about the employee turnover, it's very costly. If you hire a new employee, let's say if you got hired as a pharmacy intern at the retail pharmacy, the first day, day zero, on the day one on the job, you really don't know what's going on. So you need to go through a lot of orientation, potentially some other certification program or online module to learn about what's been asked of the position. And even before that, you also need to go through some recruiting process of doing an interview. And that's a lot of manpower that's been invested to fill such position. And it takes a little while for a person who got freshly hired to be up to the par. So the hypothesis is if there's a high turnover rate, then the employees are not well performing in their job as much as you like. Therefore, you have less satisfied colleague. Customer satisfaction is low because the employees keep changing in the store, and your profitability goes down. So that's the basic model that they established, and they're trying to test it out. So based on the data that they're available, there are some additional analysis that was ran, and finally, here's the result. It wasn't quite as what we expected. What they found was the employee turnover rate was not very relevant to the financial performance. Some store that had high employee turnover rate actually had some great successful fiscal year due to satisfied customer, due to satisfied employee colleagues. Some stores had a low employee turnover rate but had a really, really bad fiscal year. So the data analyzed did not really support the hypothesized causal model. So what do you do at this moment? Do you just throw away the model? A simple analyst or intuition might say that, but in the predictive analytics, you want to peel the layer of onion and try to do some more deeper examination of what's going on. So in this case, you do something called a subgroup analysis to find out what are some relevant factors. And in this case, that they found was that stores that had low turnover rates among the managers had a very successful fiscal year. Stores that had a very high turnover rates among the manager position had a bad successful fiscal year. So some store had a very high overall employee turnover rate because engaged manager in the store knew what's going on at each aspect of the retail store and was willing to fire somebody who was slow and not catching up or slacking, and encourage those ones who's been effective at the job to help them stay on, help them seek additional growth opportunity, and so on. So the stores that had a very engaged managers who stayed on for a very long time, know exactly what he or she is doing, had a successful fiscal year. More data analysis also revealed that the employee turnover rate is related to the socioeconomic status of the region the store was located into. So you can kind of imagine that if your store is located in a metropolitan area where you have abundance of the workforce willing to work for a low-wage job, simple task, then if you fire somebody who's low performing, the quick turnaround rate of getting somebody hired to perform this low wage job was very easy. But if your store was located in a rural region of the country, you don't have the luxury of having an abundance of the workforce available. So simply firing for the reason that the person is low performing made the position open for a very long time. It allowed other employees to suffer because they now had more work to do because the position was not filled at the time. So there are a lot of different aspects that played along to keep the employees happy that is relevant to the employee turnover rate. So bottom line is, on the face value from the simple analytics, employee turnover rate did not really affect the employee satisfaction. But what really mattered was employee turnover rate amongst the managerial position was affecting the overall employee satisfaction, which yielded high or low fiscal year performance based on the manager's effectiveness. So you can kind of see how the management intuition, this consensus business model, was partially correct. Employee turnover rate measure the success of the outcome or the profitability of each store, but employee turnover rate of the specific position was very relevant. So now you can kind of narrow down to find how to better engage and grow the managers to stay on as part of your action items, right? So you have this conclusion that, you know what, if managers are engaged, if they stayed on with the company for a longer time, then we have a potential for getting a larger profit from each store, therefore a successful fiscal year. So now the whole company-wide initiative can be built on in terms of how to incentivize the managers, how to help these managers to grow within the position so that they stay on longer with the company. Once you have identified the right drivers through a causal model, the second step in the process is setting the target for these non-financial measures. You hear a lot of times that more is better, right? 100% of your employees or your customers needed to be satisfied in order to meet the goal for the company or clinic or a retail shop, which may be true, which is logically makes sense, but does it make sense in terms of the financial performance? I try to think of this kind of a paradox and as a student a lot. So if you are studying for an exam for multiple courses and you know that this particular course you have an opportunity to get around 95 out of 100 in terms of your final exam. So the logical thinking is if it's 100% needs to be achieved in order to be 100% satisfied, one may say that you might want to spend more time trying to bump up the score from 95 to 100, but it doesn't really kind of make sense. The bang for the buck is not there. You'll rather spend that time studying for other course to bump up other courses a score and leave the 95 score as it is because you have enough to achieve the outcome of A in this case. But in terms of the monetary perspective in the business side, there are a lot of companies that have a considerable difficulty in setting the goals for non-financial performance measures. One, it's because we, as a human, have a mindset of more is better. 100% needs to be satisfied to achieve the 100% outcome. But kind of have that mindset of what is enough is difficult to judge. Also, it becomes especially more complicated in the a language of healthcare because setting a target goal for different measures when there is no common denominator becomes a little bit more complicated. So, for example, is 10% decrease in customer complaint equal to a 10% decrease in prescription fill error rate. Those are two different parameters that you're looking at, right? One is customer complaint and the other one is the prescription refill error rate, because your employees are tired and are kind of pushed to fill so many prescriptions at given crunch time. So, and you can kind of see that, one is more severe than the other. Customer complaint may lead to unsatisfied customer, therefore you have no customer coming back to your store, versus you can lead into a lawsuit by having a lot of error rate at the store. So you have to pick and choose your battle and game. If you're putting yourself into a clinical setting, 10 millimeters of mercury decrease in systolic blood pressure is equivalent to a 10% reduction in FEV in asthma clinic. Two are very different, and some may have different assessment than the other, depending on what type of prevalent disease state is available surrounding the areas that you're serving, right? Finally, other questions that one might ask is preventing one person from experiencing nausea, vomiting, and diarrhea equivalent to preventing one patient death by the drug side effect? Two totally different outcomes. So this metrics is very, it needs additional assessment and kind of more logical thinking when you're comparing apples to oranges in this case. And we've been talking over and over again that in healthcare, money in does not equal to money out. So there are a lot of moving factors that influences the outcome. So you need to gain an eye for assessing those lost opportunities, as well as you assess and finalize or setting the right target to assess the outcome. So let's continue talking about the major chain retail pharmacy. The general observations from the consumer satisfaction survey studies that are available in relation to healthcare or in any other retail settings, the general observation that they made was more satisfied customers recommend the company's product or the company to others. So this positive word of mouth is very important. Also, another observation on the other side is this satisfied customer complained to others about the product or the company. So the power of negative word of mouth. This kind of a study became very important in the auto industry in the past, and the study revealed that if you have a very positive relationship with the car that you have purchased, you tell to one of your friends saying it's really good. But if you're dissatisfied with the car that you have purchased, you actually talk to 10 different people and complain about the car that you purchased. So you can kind of see that in this specific scenario, that the negative word of mouth, even though it's just a simple opposite side of looking at it, the negative word of mouth was very, very powerful compared to the positive word of mouth. So logically, you want to hypothesize, saying greater positive word of mouth increases the future financial performance, and greater negative word of mouth reduces the future financial performance. And let's take a look at how we can apply into our example of reviewing this major chain retail pharmacy. Internal analysis of the major chain retail pharmacy revealed that when they took the customer satisfaction rate, the overall customer satisfaction rate, one from a scale of 1 to 5, 1 being low and 5 being high, they found that those people who had relatively satisfied of scoring 3 and above gave a general recommendation about 70 or 80% of the time when they met other people. On the other side, when they looked at customer satisfaction, those people who actually said 1 of being not very satisfied, 100% of the time, people go out and talk to their peers or friends, not recommending the place that you just visited. So based on this evidence that you have, what type of target will you be setting for your team? And I would like to have a quick discussion about this before moving on to the next lesson. So basically, you could have two different options. You can set a target to meet the general customer satisfaction rate of 3 and above, or you can take a general target of avoiding the customer satisfaction of 1. Based on the information that we have regarding how powerful the negative word of mouth is in relation to the auto industry, it might make a little bit more sensible decision to suggest to avoid the negative word of mouth by avoiding to get a customer satisfaction of 1 in this case. Let's take our discussion into a little bit more advanced by looking at some additional players, and this example of looking at the retail chain pharmacy. So our hypothesis was a more satisfied customer comes for prescription refill in the future. More satisfied customers coming into the retail shop will also purchase more retail items, so it increases the profitability. Despite this considerable expenditures on this market research, this company had really little insight into whether improvements in this customer satisfaction ultimately produces increase in future financial performance. So again, we're still at the place of consensus-based decision rather than data-driven decision. So the chief financial officer at the institution is desiring more detailed evidence about whether customer satisfaction should be used for marginal performance evaluation, compensation program, and corporate strategy. So let's take a look at this a little more advanced plot to advance our discussion. So we live in a data-rich environment. So given the data, you performed analysis of the customer revenue growth. Again, this part looked at the customer satisfaction of a year 1 and a previous year and predicting this year's revenue. What revealed was originally you have put a target goal of get everyone above 90% satisfaction. The satisfaction scale is from 0 to 100. 100% satisfaction means really, really satisfied customer with absolutely zero complaint. And the organization's target goal was 90%, getting a 90% satisfaction from all the customer. When the data was analyzed, it revealed this type of relationship. As the customer satisfaction goes up, the revenue goes up in the company. But there is kind of like a weird steps going on around 60%, right? So you right at about 70, between 60 and 80, the linear relationship is gone, and around 80% to 100%, there's no additional profitability by gaining additional satisfaction. So one may think that the 90% satisfaction target may be too overachieving and may not really translate well with the profitability of the company. So rather, more logical goal is kind of looking at a sweet point of setting a target for getting everyone above either 60% satisfaction rate or 70% satisfaction rate, because added satisfaction that you gain through upgrading the shelf, upgrading like getting a nice smell in the store, doesn't really matter as long as you have enough satisfied customers to draw up the revenue at the store. So far we have looked at somewhat a simple problem of how do we increase the profit for the for the retail store, and kind of really dissected and peel the onions into looking at different layers, going from customers to employee satisfaction. So you can kind of see how the customer metrics or the employee metrics are linking to the financial outcomes, and these are done really well through the predictive analytics by looking at the data that are existing in order to predict the future. So we're going to look at a little bit more comprehensive example in relation to the diabetes clinic moving on. So we have this problem, Diabetes Clinic. Eagle Physician is a multidisciplinary medical group with 11 offices located in Greensboro, North Carolina. This physician group provides 15 specialty services, including family medicine, internal medicine, pediatric, OBGYN, endocrinology, GI, sleep, and many others. Majority of the patients at Eagle Physician carry Medicare through Optum Healthcare Insurance Company. Recently, this Optum Healthcare Insurance Company has raised a concern toward Eagle Physicians regarding their large number of patients with uncontrolled diabetes. Having many patients with uncontrolled diabetes is a concern to Optum because of the HEDIS measure. Optum might be at risk of getting low quality measure, i.e. the star rating. We looked at how the star rating 0.5 is related to $8 million in revenue, extra revenue for a company. So Optum might be at risk of getting low quality measure, and that's a problem. Optum, the insurance company, threatens Eagle Physicians. The insurance company will drop the clinic from the in-network preferred choice list unless Eagle Physician improves % patients with controlled diabetes by June 15th of next year. You're a pharmacist at Eagle Physician. The medical director approaches you to produce a protocol to better manage patients with diabetes. What evidence-based services should you provide? So we have a very simple question. We're at the risk of losing a lot of patients because we're not serving the diabetes patients appropriately or caring for diabetes patients. And you as a clinic pharmacist is coming up with a protocol, sound, reasonable protocol to implement it so that you can control diabetes patients. Sounds very familiar as a clinical pharmacist to achieve, but you can kind of see the global assessment of how your work is directly related to the clinic's financial gain. So we're going to try to attack this problem solving of coming up with various pharmacist-led intervention and more from managerial side. So again, to identify or put yourself into more diagram relevant information, you're a pharmacist at the Eagle Physician, and currently the Eagle Physician is not doing good in terms of managing patients with diabetes. Of all the diabetes patients that you have, you realize through the data analytics that you only have 22% people having well controlled under the definition of healthcare, health insurance. Optum is the insurance company that these patients carry, and Optum is related to the CMS, bound by the CMS because of the Medicare. You have a, you need to achieve the 5-star rating through the meeting the minimum standard for the HEDIS measure, and that's very important. So if you get a bad star rating, you're no longer going to get patients from insurance company. You will not have any patients to serve because you got your ties severed by the insurance company that funneled a lot of Medicare patients. Your clinic goes bankrupt and you no longer has job. So that's a sad story. So what you need to do is you need to get a good HEDIS measure or quality measure score in order to avoid this bad consequence of your clinic getting bankrupt. So what you need is, I guess, at least 70% of diabetes patients who are controlled, who has controlled A1C level. So what I'm going to do is I ask you to review this following 2 resources. And we're going to have a discussion about which A1C goal would you like to target, whether it's A1C less than 7 or A1C less than 8 or 9 or 10, and what other goals should you set to meet the star rating standard. Well, hopefully you guys kind of pause the video and actually review the two resources. So answer to the simple question of which A1C goal would you like to target, I hope it makes sense to target A1C goal less than 8%. Guideline recommended A1C goal is less than 7, but in this case, that's kind of overshooting for the amount of effort that you're allocating to meet this a little bit more tight goal, because based on the HEDIS measure, the success control of A1C is less than 8 to give a little more leniency. So you as a clinician can make an argument that I want to set the goal to call success of the therapy intervention by achieving the A1C goal less than 8%. What other goals would you set to meet the star rating standard? This is also relevant terminology after reviewing the Optum Health Plan's HEDIS measure for Medicare. There are 3 different measures that calls for comprehensive diabetes care, CDC. And there are different weights. So the highest weighing is really meeting the A1C goal. And that's why we kind of focused on setting the goal for A1C first. But there are 2 other measures that are important in relation to HEDIS measure for comprehensive diabetes care, which are getting a foot exam and getting a eye exam. So you want to make sure that those are being all checked off by having a protocol set to establish the referral system for nephrology and eye exam. After reviewing some evidence, once you set the right target for your approach, you need to kind of further assess what you have and what you don't have in order to come up with action items that can help you achieve the final goal. But first of all, the hypothesis that you're establishing is you want to have an evidence-based pharmacist-led diabetic clinic intervention that will improve patients with A1C level of less than 8% from 22% to at least 70%. You kind of know that the strength that you have is an in-house pharmacist, but your in-house pharmacist has been managing people with hypertension and not diabetes. So despite having an advantage of having an in-house pharmacist, ego physicians have little insight into effectiveness of pharmacist-led diabetes clinic producing increase in future financial performance. So your medical director is asking you for more evidence and more assessment. So first thing that you need to do is recollect back from the strategic planning. You need to really assess what you have and what you don't have. And you can do that through the SWOT analysis. So I've done a quick SWOT analysis for us to have a discussion in class. Again, as a recall from a brief review of the SWOT analysis that we saw from the strategic planning lecture, strength and weakness is really assessing your internal strength and weakness, what you have, what you don't have. Opportunity and threats are what are external, controls that you don't have, but potentially could take advantage of or potentially plan to avoid. So there's some strengths that I have identified in relation to our clinic and Eagle Physician. We have in-house pharmacists, we have in-house endocrinologists, which are really great, and we have a very high functioning EMR system for a good internal communication and good documentation, aka having a very, very good data in the house. Weakness is historically poor management of diabetes, and this is basically what caused us to be in this trouble at this moment. We only have 22% of about 100% patients with diabetes who are controlled, and we need to improve that by triple or quadruple. What about the external opportunity and strength? Opportunity and threats. So the opportunity that we have is there are a lot of buzzwords about interdisciplinary medical team. And the medical societies is highly encouraging different disciplines and medical teams to work together. There are a lot of evidence-based literature about the effectiveness of the pharmacist-led intervention. So we might use this as a best practice example and try to see if we can adopt it. But again, we reviewed it earlier in this lecture how best practice in different clinic may not be the best practice for you. So you have to have a clinician's and managerial eyes on whether that is adaptable and effective to your organization. We also have an opportunity that HEDIS calls for A1C less than 8 be controlled instead of 7 based on the guideline-directed goal. So that's an advantage for us because we have a little bit of a leniency in that sense. The threat is we really have less than 1 year of timeline, so we need to get this going. So again, the whole concept of linking non-financial metrics to financial metric, we have a pretty specific financial gain in here. We avoid bankruptcy by having no patient who carry Medicare through Optum Healthcare means no patient that we can care for. Therefore, a medical clinic may go bankrupt and you no longer has job. Financial gain for other side is if you achieve this outcome, you continue to be in the in-network preferred medical group for Optum Healthcare to continue manage Medicare patients, and potentially you might be at a position of getting a more financial support from government fundings as well. All in all, the financial outcome is right there. You get a good care for the patient, then you continue your service. What are the clinical metrics that you can look? We first looked at A1C less than 8 being our goal, and we want to improve the 22% we're controlled at this moment to above 70. And in order to achieve this, we need to kind of recommend the evidence-based interventions. And how are we gonna do that? We're gonna look at some evidence. So what type of service should you support based on the evidence-based pharmacist-led diabetes clinic literature? You can go rogue and say, you know what, I've learned from pharmacy school, from my faculty professor, that this service and that service are very hot and very effective. But that's not a very good argument to convince your medical director to implement that because there is a high money at stake. So you want to make your argument as soundproof as possible. And in order to do that, the best way is really reviewing the evidence and suggest the evidence-based services. So I have identified this article for you. Take a quick look at it. And let's continue on a discussion about what kind of 3 specific services you like to implement to improve A1C and listed in the order of most relevant or importance to the least. And I will say provide your reasoning for your ranking. So I hope you guys had a pleasure of reviewing the article. We're gonna take that article's result and incorporate into the analysis result in the financial model. So again, recapturing the diabetes clinic at Eagle Physicians. Eagle Physician needs to improve diabetes care management to keep the customers, and you are asked to come up with the evidence-based interventions to help save the clinic. So these are the general 5 categories that I have identified through reviewing the literature. The endocrinologist visit, use mail order pharmacy, insulin persistence, number of glucose self-testing refills, and age are the really statistically found to be significant in terms of controlling the A1C based on the article that was published in JAMA Network. And as a good scientist and clinician, we're going to take this advice and try to complete a predictive model. So based on the relative risk of hazard ratio, you rank it from the highest impact to the lowest impact. Based on the literature, it suggests that the hazard ratio, or in this case, the benefit ratio of visiting the endocrinologist has the largest impact in improving the A1C. The next one is helping patients signing up for the mail order pharmacy. Potentially, this will help people to continuously have the supply of the medications delivered at their doorstep. and insulin persistence, that was measured through the number of insulin refills. So as you can see, those kind of two measures are relevant, because if you signed up for the mail order pharmacy for auto refill, then the insulin persistence rate is going to go up as the insulin will be delivered to your doorstep conveniently at the right time that you signed up. And number of glucose self-testing refill was also mildly relevant to A1C improvement, as well as age. But as you can see, the age was not modifiable factor. So the things that you have control is having to build a protocol so that patients with diabetes see the endocrinologist first, and then you manage it strategically. Perhaps have a pharmacy service to help this patient set up mail order pharmacy. When you dig a little bit more deeper with the literature, the authors suggest the reason why they think that this type of behavior is related to A1C improvement, and a lot of them are relevant to patient engagement, patient accountability. So having to have a good education about how to use insulin, why is consistent use of the insulin is best for A1C control, is a really large part of the job that you can do as a clinical pharmacist. So you focus your effort in this. You suggest to your medical director that you want to focus your effort on creating a educational session to teach about importance of continuing the insulin therapy, continuously monitoring the glucose self-testing, self-monitoring thing to improve the patient engagement. So that's really targeting the one outcome of A1C improvement. But like we have kind of reviewed that when we reviewed the Optum Health's comprehensive diabetes management HEDIS measure, there were two other HEDIS measure that you can target at the same time at your diabetes clinic, right? You can, one, screen for the diabetes eye exam time and refer it back to the endocrinologist to give a referral to the eye doctor or kidney doctor to get it screened annually. And boom, boom, that's another two additional factors, HEDIS measure that you're targeting at your assessment. So overall, hopefully all these evidence-based services that you have recommended kind of really become fruitful and end up having a lot of people with diabetes under control under the eyes of HEDIS measure. So if the pharmacist-led diabetes clinic works and HEDIS measure improve, what happens? Optum will get better star rating, which means more patients will sign up for Optum's Medicare plan, and more patients through Optum Medicare plan means that more patients will have opportunity to choose Eagle physicians for chronic care management, and that all in all means a lot of dollars for both insurance company and for the clinic. And again, the final outcome of Eagle physician not going bankrupt is a really gain on your position as a clinical pharmacist at the clinic. All in all, we have really spent substantial amount of time reviewing the idea of linking the clinical or non-financial metric with the financial metric. Once everything turns out to be fine and you are at the position of formulating the financial metric report, this is the rough idea of how the balance sheet or income statement, cash flow statement are established based on the billing and reimbursement that you get as a clinic. And Dr. Dean Lingle will help you guide through on how to read this type of document for the next couple weeks. Again, using analytics to choose action plan, we saw over and over again how important this is. But many are not perfect. Examining non-financial metrics in isolation of other related metrics is not especially sophisticated and really can lead to misleading or incomplete inferences. So we talked about how if it's data-driven decision, can just the computer guy do the assessment and give me the answer? The answer is no, because you need a clinician's eye to really examine what's going on and make a sound decision. So with that, hopefully you've got the sense of making managerial decision from the clinician's eye. As a pharmacy student, we've spent considerable amount of time learning about clinical and humanistic outcome, and we will further endeavor our adventure in trying to link this non-financial metrics with the financial metrics to assess the success of institution as we learn more modules in the pharmacy management course. With that, that's the end of it, and have a great day and see you next week.